Good morning. Welcome to the 2014 Debra L. Spunt Lecture, generously funded by the Laerdal Medical Corporation. I'm Mary Fay. I'm the director of the Debra L. Spunt Clinical Simulation Laboratory at the University of Maryland School of Nursing. I was privileged to know Debbie when I was a graduate student at the University of Maryland. A pioneer in clinical simulation, Debbie was dedicated to the development of the school's 24 clinical simulation labs, and our labs are now named in her honor. Debbie's expertise in clinical simulation is recognized worldwide, and it was through her leadership that the University of Maryland participated in the landmark NLN Laerdal study, designing and implementing models for the innovative use of simulation to teach nursing care to ill adults and children. Debbie's legacy and contributions to simulation education have influenced many of today's simulation leaders. It's now my honor to introduce Dr. Kristina Dreifuerst, who was selected to deliver this year's Spunt Lecture. Dr. Dreifuerst is an assistant professor at the Indiana University School of Nursing. Her research on innovative teaching methods to improve students' clinical reasoning skills has been funded by the Robert Wood Johnson Foundation, the National League for Nursing, Sigma Theta Tau International, and Indiana University. The teaching method she developed, Debriefing for Meaningful Learning, has been adopted by schools of nursing and interdisciplinary schools in health sciences across the US, Canada, Australia, and the United Kingdom for use in clinical simulation and other clinical settings. Dr. Dreifuerst is truly one of today's thought leaders in nursing education. She's the recipient of numerous awards recognizing her research from organizations such as the Midwest Nursing Research Society, the National League for Nursing, Indiana University, and the International Nursing Association for Clinical Simulation and Learning. Her creativity as an educator has also been recognized by the Wisconsin Nursing Association, Indiana University, and the International Nursing Association for Clinical Simulation and Learning, among others. An accomplished teacher, researcher, and mentor, she embodies the ideals that were so valued by the Laerdal Medical Corporation in the course of establishing this lecture: a commitment to excellence in nursing education, in particular, leadership in the design, development, and implementation of simulation in nursing education. Please join me in welcoming Dr. Dreifuerst as she presents Reasoning and Practice Education, Debriefing in, on, and beyond simulation.
Thank you. It's a pleasure to be here. Quite an honor, actually. I truly stand on the shoulders of giants. I am so grateful to the NLN and to Laerdal for sponsoring this lectureship. Only one thing, well, at least one thing, would make today better, and that would be if my friend and colleague Debbie Spunt could be sitting in the front row, because she would be amazed to see the fruits of her labors, not only with me personally, but with simulation in general. I knew Debbie, I had the privilege of knowing her early in my career, and she was definitely instrumental in helping me formulate where I would go and what I would do. When I was thinking about doing this talk, I was thinking about all the important things like what to wear. And the last time I saw Debbie was about 6 months before she passed, and we were in Baltimore and it was unseasonably cool, and I wasn't prepared for that. And so she gave me this fleecy sweatshirt to wear. And then when we were done, I was going to take it off, and she said, "Oh no, you keep it." Truly, I thought about wearing that today. So here we are, and it's Saturday, and our summit is almost over. And I wonder, if you think about it, what you would think is the most wonderful thing, the most significant thing about the last few days. If you thought about it, what would first come to your mind? And all of us saw that people moved around from session to session. So some of us didn't make the best choices. So if you had to think about the thing that you would change the most, what would it be? I know for me, I would bring different shoes because I have blisters to take home. Now, the interesting thing is this is my, 15th summit, And I seem to have this problem every time. So clearly I don't learn anything. For many of our students, debriefing is just what we just covered in about 15 seconds. What went right, what went wrong, and what would you do differently? But it can be so much more than that. And so today, although I'm going to talk about debriefing for meaningful learning, which is the debriefing method that I developed, we don't have enough time for me to teach you how to do that. So instead, we're going to use elements of it. We're going to talk about things that could be different in debriefing, things that you can do beyond what went right, what went wrong, and what went differently, or what would you do differently. Now, I want to tell you there's nothing wrong with those three things, but it's not enough. For me, the goal of simulation and all clinical learning is to help students develop clinical reasoning. So I think we better stop right here and talk about how I define clinical reasoning, because there's a lot of confusion in the literature. And my definition is really based on some of the definitions that our colleagues in EdPsych use, in neuroeducation psychology. They are rapidly studying learning and how learning develops. And it's a landscape that is changing week by week by week. So really for us, we're going to talk about clinical reasoning today as higher order thinking. And in addition to higher order thinking, it includes the presence of reflection and metacognition. Those are the hallmarks. That's what makes it a higher order thinking than critical thinking or clinical judgment, because it has the metacognition and the presence of reflection. Now, some of you, I can see it by your faces, really I can see your faces, that you're shaking your head because you're arguing, you're saying, no, that's not the definition that I use. And I just want for us today to agree to disagree on that point. For me, this is the framework that I'm using for what we're talking about. So debriefing. Debriefing is the part of simulation that can help us develop clinical reasoning skills in our students. Now, we have emerging literature, emerging evidence that's showing us that debriefing is the most important part of simulation. And so because of that, we need to think about what is it that is so important, and how can we expand upon what we do to capture that importance for learning in our students, and what can we do to augment that learning and make the most of the time that we're spending with students. We want to advance higher order thinking. And in order to do that, we have to do more than say what went right, what went wrong, and what would you do differently. We have to ask questions that are deeper, questions that help students to develop reflective thinking. Now, here's the interesting thing about reflection. For those of us of a certain age group, if you were a 1960s baby or born earlier than that, reflecting is not hard for us to do, because it was part of our K-12 education and part of our societal life at the time. But with the advent of No Child Left Behind, the whole landscape changed, and our learners changed. And because of that, they don't reflect well at all, because everything was about, tell me what I need to know, and I'll tell it back to you. And how did we test that? We tested that with multiple choice tests. And I don't care what any vendor in the exhibit hall told you, if all of the answers are given, multiple choice answers are given, then you come to the right answer by induction or by deduction. And doing that is not higher order thinking. It doesn't develop reasoning skills. And it really does a disservice to our students. Because I don't know about you, but in my nursing career, not once have I gone into a patient's room and the patient has pulled a little card out of the pocket of their gown and said, nurse, my problem is one of these 4 things. And if you figure it out, we're all good today. So debriefing helps us help students think differently so that they are prepared for practice. So how should we do this? We need to think about guiding their reflection, teaching them to reflect and teaching them to think. That means we need to help them think in, on, and beyond action. Now, what does that mean? So reflecting or thinking in action is thinking in the moment. It's what's happening in the moment. And sometimes as a clinical or simulation instructor, if you're very, very lucky, you will see it happen. You will actually look at the student and you will see the wheels turning. You will see them look here and look here and look here, and you can just see it. And you want to say, stop! Whatever you're doing right now, that is thinking in action. But of course you can't. So we have to remind them of those times. That moment, that is it. Then we have thinking or reflecting on action. So that's the retrospective thinking. And it's really the hallmark of the expert nurse. It shows that you are advancing from a novice to expert. You are on the continuum. Now, you all know this because you can be walking home out the unit to your car, or you can be driving or on the train or on the bus, making dinner, and all of a sudden, your mind goes back to something during the day, and you're thinking about a patient situation, and you're remembering either something you did do or something you forgot to do. Or that dreaded 3 a.m. when you wake up in the middle of the night and go, oh, crap, and you remember something that you forgot. That is your mind processing, reflecting on action. And we have to teach students to do that, because the quicker they can learn to do that, the quicker they move along the continuum. Because what they're doing is they're putting those events into their mental Rolodex. They're framing up, we call it. And they're trying to frame correctly. So regardless of what happened, the reason you remember those things in the middle of the night is because typically they are a critical event, something that happened when you reflected on action. It's a critical decision point, and you're coming together to put it correct in the frame in your brain. Then there's reflecting or thinking beyond action. And for me, this is the very, very most important part, because this is the part that we need to really help novice nurses learn to do. When you are an experienced nurse and you hear patient report, or you hear about a patient, and then you walk down the hallway toward that patient, or you walk toward them in the room, you are beginning to anticipate what it is that you're going to find based on the data that you heard. There's a very close relationship between anticipation and reflection. You cannot anticipate without reflecting, nor can you reflect without anticipating. They are relational concepts. So the more that you anticipate, you are anticipating because of things that you know, things that you've put together, whether it's knowledge, whether it's experience. And then when you get to the patient, anything that fits, you begin to assimilate, and it fits. And so you continue on your thought process. And anything that doesn't fit, you have to accommodate for. You have to decide, is this okay, or do I need to do something different? Is my frame correct, or do I need a different one? Now, we need to teach students how to do that. And unfortunately, in our current educational system, the way we teach nursing, our concepts are so siloed that students learn and think about them siloed, and they have them framed in their mind siloed. So when you have a student who thinks that they're going to take care of someone with hypertension, and then they have hypotension, they get all flustered, because to them they're not relational concepts. They're things that they learn separately. To us, we think, well, it's all about blood pressure. Well, that's difficult for them to do because of how we've taught them. So debriefing is the time when we can bring these concepts together. The second thing we have to do besides teaching reflection is we have to learn how to be okay with challenging, taken for granted assumptions. So what that means is that in debriefing, you need to engage in dialogue with students, not only about what you think they did correctly, but also what you think they did incorrectly. both of them, so that they don't think that you only call on them when they did something wrong. Why is that? Because I have learned through this journey through debriefing that many times students and practicing clinicians can do the right thing for the wrong reason because the frame isn't quite right. They give the medication, they do the action, they do the assessment, but what they're doing it for, the reasons behind it, don't make any sense at all. And so if we don't capture that, then they don't learn that there's a mismatch. And you can get away with doing the right thing for the wrong reason a couple of times, but you can't get away with it all the time. So you need to be very careful as you are working with students, particularly in simulation, that you're asking them, tell me, I saw you do this, tell me why you did that. And what does that mean? And what were you thinking? And what did you expect would happen when you gave that intervention, and why? Those are really, really important things, even when they do it right. Because too often, we see them do the correct action, and we move on. And we don't know that there's a disconnect. And then when they get into clinical practice, there can be real serious consequences. By doing this challenging for taking for granted assumptions, we are teaching and practicing thinking skills with our students. And thinking skills are probably more important than technical skills these days in nursing. And I say that with great confidence because pretty much all of the technical skills we do as a nurse, we now teach patients and families to do at home. But the difference between them and us is our thinking skills. So we are still connected to the process of them doing the technical skills because we do the supervisory thinking skills. So if we don't pay careful attention to thinking skills, our nurses are really no different than our patients and families out there doing stuff. The best way to do this teaching and practicing of thinking skills is through Socratic questioning or Socratic dialoguing. You heard me a minute ago say what, where, why, how, tell me, tell me, tell me. You use those open-ended questions to uncover thinking and to dialogue about the process. But I want to caution you. You don't want to just be barraging them with questions. It's one thing to ask good questions, but you also have to listen for the answers. And I want to be really, really clear here. Questions that drive learning, particularly meaningful learning, often cannot come from a prescribed list or a set of objectives. They arise in response to the learners and what has gone on in the sim, what is going on in the debriefing. What does that mean? That means that even when I spend an entire day debriefing 100 students on the same sim over and over and over again, every debriefing session is unique and different because it's in response to what the students did, not in response to what the sim was supposed to do. That is the difference between meaningful learning and rote learning. And then there's active learning. And so active learning is the process of getting to meaningful learning. So in active learning, let's be clear, that's where you have to be engaged in the process. You have to notice and reflect, assess your own degree of understanding, and challenge those taken for granted assumptions. You have to participate and contribute, and you have to actively gather information, think about it, and problem solve. Now, there's a lot of unactive learning happening in our programs today because we're doing traditional person at the stage telling the information, which is kind of ironic at this very moment because that's what I'm doing for all of you. But nonetheless, in order to engage your students in learning, we need you to always be thinking about making sure that everyone is noticing. Everyone is reflecting, everyone is participating, contributing, thinking, actively working in problem solving and dialoguing. It's because of that that debriefing works for everybody, not just the people who were the players in the sim. And by the players, I mean you're the nurse, you're the patient, you're the medication nurse, you're the charge nurse, you're the patient's family member. That is not necessary to debrief. What is necessary is that everybody who observed, everyone who had a role, either active or observation, participates in the debriefing. And so your job is to engage the group. Everybody needs to contribute. Why do we care about active learning and debriefing in SIM and in really all clinical learning? Because the neuroeducational science is showing us that if students have not been actively engaged in building explanations and reasoning with the evidence and making connections, or having the opportunity to look at things from more than one perspective, then there will likely be gaps in their ability to understand or apply knowledge in practice. And they have clinical models that are showing this over and over and over again. So this is important for us because it's not enough to have more SIM. You know, we heard that it's okay to have more SIM, but I'm here to tell you it's not enough to just have more SIM. You gotta have more SIM that is seriously and effectively active learning for all participants. Interestingly enough, going along that vein of active learning, remember I started this by telling you that clinical reasoning was important to me? Well, just like active learning includes being involved and really working with the knowledge, clinical reasoning is fostered by the comparing, analyzing, hypothesizing, generalizing, inferring, synthesizing, and reflecting on what has occurred. And that develops metacognition, which is the hallmark of that highest order thinking. So all of these things make sense. We're making a circle and it's making sense. So I want to turn the lens a moment, and I want us to debrief in simulation. So in the moment, today, 2014, where are we at with simulation and debriefing? Right now, I would say that most schools use some kind of simulation to some extent. But I would say very few teachers who are using SIM in their classes are actively developing the SIM to uncover thinking. I think very few of us are actively saying, what kinds of thinking did or does this SIM and debriefing promote ahead of time? What are we trying to accomplish? Because I hear a lot of teachers talking about SIM and clinical, and I hear them talking about types of patients, patient diagnoses. I hear them talking about skills, technical skills. I hear them talking about performance. I hear very little conversation about thinking. But if students have not been actively engaged in building explanations, reasoning with evidence, making connections, having the opportunity to look at things from different perspectives, remember, the science is telling us there's likely to be gaps in their understanding and their ability to apply knowledge into practice. Time. As we think about debriefing in simulation, I think we have to talk about time. So you can guess that I'm thinking that if the science in our nursing simulation evidence is developing and showing us that debriefing is the most important part of simulation, then we ought to be spending a whole lot more time on debriefing. And so I'm here to challenge us to think outside the box about time. You know, we are controlled by the almighty hour. That 60-minute interval, you know that 60-minute interval. And so often I hear, we did a 20-minute sim and a 40-minute debrief. And I want you to say, the next thing out of your mouth should be, was that enough time? Because I'm thinking probably not. And I'm thinking that if we really want to uncover thinking, if we really want to connect the dots for folks that we're working with, if we really want to help them reflect in action, beyond action, and on action, that we need to think about a whole lot more time. Now, this is usually when somebody in the back raises their hand and says, just how much time are you talking about? I don't think we know that yet. I think we have to spend some time researching that. But I'm guessing that it's going to be significant. You've heard of the flipped classroom? I want to challenge you to do a flip sim. I want to challenge you to have the majority of your sim not be the time with the mannequin or the standardized patient or the virtual piece. I want to challenge you that the most time significantly should be in this process of teaching thinking. Finally, the third thing for debriefing and simulation is I think we have to think about consistency in debriefing. People who use DML will know that I am a staunch advocate for consistency, that every time you debrief, you should use the method and you should use it consistently. Now, that's not just a random thought on my part. You see, consistency helps us develop thinking routines. And practicing thinking is just like practicing any other skill. The more you do it, the better you do it. And you see, what is initially awkward then becomes intuitive. And you know you've crossed the chasm when you've been using Socratic questioning and this thinking practice with your students for long enough that they begin to use it with you. And I would suggest that if you're going to be using this, that you let your colleagues know, because I get many emails that say, now here's what happened. We were doing this in sim, and we've been doing this Socratic questioning, and the students are really, they're starting to do it themselves. So I don't even have to ask the question. I start the conversation, and then for the next hour, they take it themselves, and they question themselves using this Socratic questioning. And that's fine, but then they go to lecture next hour, and the lecturer starts talking, and then somebody raises their hand, and then there's 5 hands, and it's, well, tell me more, and how do you know that? And more Socratic questioning. So you want to be sure that you all understand this is going to change the landscape forever, but it's going to make better thinkers and better nurses. You see, as students become more aware of their thinking and how they reflect, they become more metacognitive. And again, that's the hallmark of highest order thinking. Now, I'm not saying you have to do the same forever. You know that when you practice something and then you get good at it, that after that point, then you can begin to change it up. And the same is true with thinking practices. Once you are comfortable with it and the students are comfortable with it and the routine is set, then you can change things up. But as you are developing thinkers, you need to be cognizant of the fact that consistency is really important. Now let's talk for a minute. We're going to turn that mirror again a little bit and talk about debriefing on simulation. So debriefing on simulation would be us as a group reflecting on simulation and where we've come, where we've been, and where we've come from. When we started this journey in our discipline, there was a concerted effort to think about simulation as a pedagogy that could be used and should be used for high-impact, low-frequency situations. All right? So here's what happened. We've come down the road, and I'm going to tell you today, every student who goes in the sim lab knows something bad's going to happen. Now, I can tell you that in my career as a nurse, I had many days in a row where nothing bad happened. But we have focused SIM on this response to the rapidly deteriorating patient. And that was fine for a while, but I think it's time to move on, particularly if you're thinking about increasing the amount of SIM in your curriculum. Because you see, we also need SIM to help students with the low impact, high frequency situations so that they can see the big picture. I'm talking about a SIM where you're going to talk, and the whole SIM is about something like an upset patient, something like a patient can't get comfortable, something like the pain medicine isn't working, something like the post-op patient is throwing up. Because I'm going to tell you, every single day those things happen in practice. And when we think about our transition to practice and our students who are going out in the big world, we've discovered that they're pretty good at the rapidly deteriorating patient, but they're not so good with the things that they encounter every day. I think that's our fault. Now, some of you may say, well, they get that in clinical, real clinical. Yes and no. Because you see, in real clinical, the student has one or two patients. They don't have a full load until they get near the end, if we're lucky. And so they don't know how to manage the crisis of one patient, all of the work of the other, and this persistent issue that is a low impact, high frequency patient situation. So we should turn the worm a little bit. You know, maybe it's a SIM that's about teaching medications, because we know how important that is. And maybe they do that every semester. Maybe they do that even more than that. I think if we are going to move to doing more SIM, we have to rethink, because you know what? They expect the gauntlet every time. So the moment that we change that around and they learn that not every SIM patient is going to crash and burn, we've made a huge stride in teaching and learning. The other thing I think we need to think about is the big picture of practice education. I think that the National SIM Study data helps us to look at the relationship between clinical and simulation more as sisters. And I think that I'm excited when I go to schools and I hear them say, today your clinical experience is in-house, because that's what SIM means. And tomorrow your clinical experience is out of the house, and that's at some community place. I think the closer that we bring these together, these experiences, the better it is for everyone. Of course, for me, that means that we need to debrief traditional clinical the same way we debrief simulation. Because if simulation is simulated clinical experiences, and we know from our increasing evidence that debriefing is the most important part of simulation, it would stand to reason that it is the most important part of traditional clinical experiences. So remember when we talked about time a few minutes ago? I think you all need to reconsider time for post-conference. And rather than it being something summarily happening at the end, that is another opportunity to bring in active thinking strategies for students. And finally, as we debrief on simulation, I think we need to talk some more about roles. I think we need to have a discussion, and we need to have a bunch more research into how important it is to be the nurse. how important it is to be the primary nurse, the secondary nurse. I was at a school a couple weeks ago. There were 7 of them in there. The nurse 1, nurse 2, nurse 3, nurse 4. Now, I'm going to tell you, I'm an old nurse. Never once in my practice, never once, were there 7 nurses, ever. And if there were, something really bad was happening. So we need to think about that. We need to think about how we can capture what is happening in the simulated clinical environment, whatever it is, and use it to augment everyone's learning, thinking learning, and how often they really need to be the one doing the stuff. Okay, we're going to turn the mirror again. And let's debrief beyond simulation, because this is pretty fun for me. So in Debriefing for Meaningful Learning, after you reflect in action and on action on the sim or the clinical experience that you've just had with the students, then we move to on action. And remember I told you that reflection and anticipation are related concepts? So what happens at this time is you say, okay, so we have just taken care of this elderly patient who has a fluid volume issue. He's fluid overloaded. We've done the whole respiratory, pulmonary thing. We've debriefed it. We've talked about it. We've dissected it. Now what if, instead of this old person with this fluid overload issue, your patient is instead a 21-year-old female patient who's 39 weeks pregnant and comes in because her ankles have swollen 3 times the size that they were yesterday. What do you know? What would you do? What's the same and what's different? Now, the first time you do this, students will say, I know nothing. I haven't had OB yet. And so your job is to help them think through. What fits? What can they assimilate? What doesn't fit? What do they have to accommodate? How do they think through the process? Because at the end of the day, in their school time with us, in their pre-licensure program, we probably have the opportunity to introduce them to the care of less than 50 patients. And in their career, we hope that they take care of 500,000 or more patients. And so we have to help them understand that what they've done with us is enough, that we've taught them to think. And so by thinking, they can think through these alternative situations. So as we think about debriefing beyond simulation or the alternative situations, I've alluded to some of this, but I think we have to think about where we're going. I think that we're going to have different simulation models. Already we talk about standardized patients, we talk about virtual sim, we talk about mannequin sim, we talk about high fidelity, we talk about low fidelity. But I think that we need to understand that whatever the model is, whatever the stuff is that we're using to simulate a clinical experience, the thing that stays consistent is the thinking part, the debriefing part. It transcends the model. And so that is very comforting to us as teachers, because even as we get new stuff, and there was some pretty nice new stuff in the exhibit hall this time, we are going to have to remember that our job as teachers is to use whatever we have, but maintain that thinking is really important. And how we teach thinking and how we debrief can be consistent regardless of the model. So what does that mean? Now, I alluded to this before, but I want to make the point harder. I think that we have to make a closer relationship between clinical and simulation, and that debriefing is the way we can do it. Now, I don't know if you caught it, but in the National Simulation Study, the people who participated were trained in DML, and it was the same people who did sim and clinical. So you can bet that there was a link. Now, we didn't study that. I wish we had. But clearly, that relationship was important. The debriefing elements can transcend the clinical environment. And they should come into the classroom. So I suggest, for all of you who teach in the classroom, that you think about flipping your classroom in a little different way. I suggest that you have them engage in whatever topic it is you're discussing before they come to class. And then you use the class time to give patient examples that you debrief them through as a class. Now, I always hear this, well, I can't do that, I have 50 students. Or I can't do that, I have 100 students. Or I can't do that, my students are online. Yes, you can. You can help them think through the problems. You can help them engage through Socratic questioning. What would you do next? Why would you do it? What did the literature say that we read? How many of you have seen this in practice? What might it look like in practice? And you fill in the blanks for them. And once you get them talking in class, instead of listening, you've flipped to active learning. And by flipping to active learning, you have changed the dynamic in terms of how students think. Now, you can't just flip how you teach without flipping how you evaluate. That almighty multiple choice test, we do it for a lot of reasons. And I'm not telling you have to get rid of it, but I want to give you a suggestion that would follow all the things that we know about debriefing. So instead of giving them 100 questions, why don't you give them 10? And give them 4 choices, and so they pick the right reason, and they have to say why. And then they have to say why the 4 that are wrong, or how they know that's wrong. Or what piece of information told them that it was wrong. You seen these Socratic questions come through? Now, it's a little harder to grade, but man, is it effective. And it requires a different kind of thinking. And so you got to know, the first one, the scores are going to be bad because they're not used to it. And the students are going to rebel because that's not how it's done. But thinking and practicing thinking gets easier as you keep doing it. And the more that you do it, the better thinkers you become. I'm not saying every time, I'm not saying every way, I'm not saying every class. I'm saying give it some thought, because you'll be surprised how that element of debriefing in the classroom changes everything. Okay, we're almost done. Going forward, we need some things. And we need some things from all of us. We need a lot more evidence. We need a lot more research. And we need good research. And we need strong research. A couple years ago in this lecture, we heard Dr. Cardo-Negrin tell us we need research. We're still waiting. We need research. We need a lot of it. So we need all different levels. We need people to do scholarly teaching and implement what we're doing and tell us how it works. We need people to be actively involved in the scholarship of teaching and learning and do some data collection within their environment. Single site, replicated things. Let us know and get that work out there. But most importantly, we need big studies. We need multi-site studies. We need people to work together to help us collect data so that we can move this pedagogy forward. Because our students and their future patients depend on it. Thank you very much. I'll stay for questions. Yep.
Thank you, Chris, for giving us some lessons on how to encourage our students to become those thinkers. And we have some time, so let's have some questions.
Are there microphones or no?
Do we have some? I'm sorry, it's hard to see from up here.
Yeah.
Hello?
Yeah.
Over here. My name is Teresa Busey, and I'm from College of DuPage. And I just want to applaud your work. And I am not here to ask a question, just to say that I've been debriefing in clinical the way I have been debriefing in simulation, and it's absolutely what you're saying is right. Watching the thinking come forth. And I haven't been saving post-conference for the very end. We've been having huddles. Exactly, you know, what you're saying, kind of debriefing in action that way, and then at the end of the day, debriefing on, or, you know, whatever. I don't get the words right, but you get what I'm saying. So
Yeah.
Thank you so much, and whoever's next, take it away.
Kristen Pretty, University of Texas at Arlington. Love watching students learn to think. I have the privilege of teaching freshmen, and you know what? They can think if you set things up for them to think. If you put a patient in front of them, they can think. It's very exciting. But the irony that I find is the lecture I spend the most time up there talking on is the language of metacognition. Is that I have a lot of slides and a lot of examples that I verbalize about how to think critically. And so I spend an hour and a half on this, and then I give them a patient to think about. And I'm not quite sure what to do about that.
I would spend less time on the lectures. I would try and give them, excuse me, 3 examples from your own work. So to teach them, this is what it looks like, this is what it feels like. Excuse me. And then build upon that the next time. Pardon me.
Hi, my name's Maria Ramos. I'm from El Paso Community College. I went to one of our meetings earlier in regards to simulation where they did a 3-patient simulation in the NIC unit. And it was very interesting how she did it, and I love simulation. But in what you're saying, my question is, she sort of went over the whole simulation process piece by piece, giving it to the students, and then they actually went out and practiced it, you know, during the simulation scenario. And there was still a lot of issues. Do you recommend for us to do that? Go over the whole simulation, what's actually going to be out there, versus just allowing them to see what they do with whatever situation you give them?
I do advocate pre-briefing. I think it's critical. I don't think that it benefits anyone to send students in for a surprise. I think that they need to know what they're going into. For most nurses in practice, unless you work in the ER, you usually get a little bit of information that helps you, get the frame right for the patient that you're going to see. So we need to teach students to use that framing, and I think pre-briefing is pretty important for that. I don't find that that negates the need to unpeel the thinking in debriefing. In fact, I find that actually it stimulates what has to happen in debriefing, because there's a big difference between how you prepare and how you get ready and how you think you are going to respond, and what actually happens in sim, and then uncovering, so why did you do that? You know, I have stories upon stories upon stories about that unpeeling the thinking and the misconnection of knowledge. Students will say, well, I read in the chapter, blah, 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 and so I did that, but it has nothing to do with what's going on with this patient. And so you have to swing back and fill in the gaps for them and with them.
Over here.
Terry Basie, University of Texas Health Science Center at San Antonio. And I just wanted to thank you. Debbie would be proud.
Oh,
thank you.
Thank you.
Cheryl Taylor, Southern University and A&M College, Baton Rouge. I really want to thank you for bringing the debriefing, the work and the research. Here's my question, because students get extremely frustrated when there is a test and these questions are thrown out and the score changed because they're obsessed with the score on the test. But then faculty have our own obsessions too. And so often what happens is an analysis is done, then good questions are thrown out for some strange reason. There's never a debriefing about that process, and a lot of stress occurs from students who got it right, but the question was thrown out. So my question to you, because you used the term scholarly teaching, would faculty debriefing with each other have anything to do with that? And how should that look?
It would, but let me back up and tell you, I think it's really important for students to understand the teaching process. I teach faculty or graduate students who are learning to be faculty in an evaluation class, and I tell them it's really important early in the course that especially pre-licensure students, to let them know that after they take the test, the work is not done, because our job is to do an analysis of the exam. And based on that psychometric analysis, and it's a really good time to start talking statistics with students, that may change, how some questions are used to assess student knowledge. And so I think you start at the beginning of the semester, at the beginning of the program, explaining that process occurs. And then when you do have to throw questions out, you articulate, based upon that process that we talked about at the beginning, this is what happened, and this is why it happened. And it's also good because it shows that even as instructors, we're not infallible. We are as human as they are. And really, we want the best evaluation process possible. So that means that we have to, sometimes take out things that maybe they got right. It just happens. But I think also we have to do that with our colleagues. I recommend, again, that we run exams past our colleagues before we give them to students, because that peer feedback is incredible. And then after the exam is given, then we close the loop with a small debriefing session. It can happen, informally in the lunchroom, whatever. But I think that we need to close that loop with each other too. Thank you.
Dorothy Otto, UT Houston. I would appreciate it if you would address the issue of teaching online. I have a professional practice issues course, and part of it is in lecture. The other half is in online strategy, and I have found it exceedingly difficult to do the same type of teaching when we have online courses, and my course has 120 students in the class. So I would appreciate if you make some comment. Is it possible to follow your debriefing
online?
Other than a discussion board, which I'm not really willing to do with 120 students because of the time.
Well, I think you have to make some decisions about what it is that you're willing to do, what it is that you're trying to do, and what it is that you need to do. And yes, people use debriefing methodologies, including DML, online all the time. But it is a method that is grounded in narrative pedagogy, so it requires dialogue, whether that's written dialogue, whether that's verbal dialogue. I don't know quite how you debrief without communication. So you'd have to figure out what you can do and what's reasonable. But I think that it is important to have good communication. You want to tell me, you want to question, you want to hear back the answer, you want to volley with the next question. Somehow you need that.
Thanks very much. I do it with my exams. Thank you.
You're very welcome.
It's Pat Reedy, Pat Reedy from the College of Southern Nevada. And I just wanted to comment that just like the students need to learn this process, the faculty needs to learn this process, and it takes a concerted effort and a little bit of practice. I wonder if you want to comment on that.
Yes and yes. It does.
Over here, Chris.
Ruth Tadessa from Oregon Health Science University. First, I just want to say thank you for making us think about thinking. I'm in Oregon. We use the Oregon Consortium Nursing Education, and we use the Tanner clinical judgment model, which includes in-reflection and on-reflection as part of their clinical judgment. I want you to help me comment on about writing reflections. We make them write about their reflections a week after they are in clinical, and then after clinical they have to submit a written reflection. And most students, after a while, they get tired of the writing part, and they think like they're doing it to just please us. So what are your thoughts about that?
Well, they are doing it to please you because you have made that assignment. I think you have to think about how the methodology translates into what's going to happen in the future. Okay, so when you think about nurses and the writing, so the bulk of our writing, if you will, even with electronic medical records, is about the patient. It's not necessarily about us. And so when you're teaching reflection, what you're trying to do is you're trying to teach them to be reflective practitioners down the road. And so there does come a point when the reflection has to stop, because that's not going to continue into practice. But what will continue is the dialogue with their colleagues, whether it's at the start of the shift, if it's during the shift, as they're talking to colleagues. So there comes a point when you have to move from the written to the oral, because that's the current environment of practice. The other thing I'll say about reflective writing is that it is damn hard for our students to do. And if any of you have tried it, what you mostly get is the diary. I did this, I did this, I did this, and you want to say, yeah, I was there, I know. But that's all that they know that reflection is, because again, in this K-12 education that they've had, that's what they had to do. That was the essence of reflection. So if you're going to do this, I strongly urge you to teach them how to do it and cue them up and work hard at getting them to write what you're looking for, because it is not innate. It is not what they think they can do.
Beverly Malone, CEO of NLN. And when I saw Chris at the beginning before the lecture started, I said, knock it out of the ballpark. You did out of several ballparks. I mean, for me, wow, it makes me want to teach. And that's something phenomenal.
Thank you. We're a little short on faculty. We can probably find a place for you.
Thank you. What I was thinking about was the research piece of it. Mm-hmm. And this is not a question, Chris. This is a comment to all my colleagues in the room. The NLN is the only organization that funds research in nursing education. Our wonderful colleagues at the Institute for Nursing, NINR, they're more focused on clinical research and and are not really allowed to connect the dots between clinical and education. So we're it. And I just want to encourage you to put the money into the research efforts, to make the contributions. I know last night we did fantastic things with the text to pledge, but I think this research issue is so critically important. And we've got graduate students who are PhD levels and other that are really starting to focus on how to do reflective thinking and metacognition and the active learning and all of this. But when they go around for funding, there's no place to get it except at the NLN. So I just want to encourage you that this is something we can do, and multiple sites, come on, let's get real, we need to do this, and that's called collaboration. So I'm just a plea and a thought that this research portion that Chris talked about is the one that frequently gets left behind because everything is so exciting, what she's talking about, that the research piece doesn't sometimes delve into us. We can do this, colleagues. Let's do the research.
Yep. Here, here.
Hi, I'm over here on the, I guess it'd be, yeah. My question is, my name's Doris Rink. I'm a nursing faculty simulation coordinator at Portland Community College in Portland, Oregon. And we have a pre-simulation time where we do go over sort of the patients, and then we allow a chance for the students to actually go in and sort of practice with the patients. What is your feeling about that? Because so then it's not like, oh God, okay, something bad is going to happen because they've already been there. So I was just wondering if you could give me your opinion of that as a strategy in teaching simulation.
I think there's merit to that. Students tell us that while we think that sim is a safe environment, it's safe for us because it doesn't hurt our license, doesn't hurt the patient, but it is not safe for students because they know that they have to be on their game. We are watching them, we are assessing them, we're going to get them later. That's what they think and that's what they tell us. And there are many students who feel like it's a performance. I have to do my very, very best. Whether or not it's high stakes or not, they perceive it to be. So what you're talking about is a way to reduce the stress, and you might get a better learning outcome because we know that when students are highly stressed, the learning shuts down. Done. So you need to bring it down, and that's a good way to do that.
We're going to have to call it end to questions, but thank you again, Chris, and hold on 1 minute before, stay with us. I also want to extend my thanks to Laerdal for making this session possible and for funding many of our simulation projects. It's been my pleasure and privilege to work with them on the National Multi-Site Multi-Method Study from 2003 to 2006, to the project that built the SIRC, a learning place for you to learn more about simulation, the ACES project that produced Millie and Red and Henry and Eartha and Julia and Lucy, and the veterans cases as well, and our ongoing project that's looking at the use of simulation for high-stakes assessment. Laerdal has always been a supportive partner, and they have never asked for any special recognition for their contributions. It has really been my privilege to work with folks who have values and live by them. I invite you to look at the Laerdal website and to read about the company's values, their vision, and that includes pride in their history, having a clear vision and a meaningful purpose, and that purpose is saving lives, a willingness to learn, a passion for continuous improvement, and dedication to improve global health. And while you're up there, take a look at Laerdal Global Health, the company that was established to help developing countries reduce maternal and infant mortality with low-cost simulations, the Mama Natalie and Baby. So please join me in thanking Laerdal for all they've contributed to saving lives. And I'd like to introduce Mr. David Johnson, President of Laerdal Americas, who is a member of the NLN Board of Governors and a very proud father of a nurse. Who is just going to make a presentation to Chris for her award tonight.
Yes, I am a very proud father of a nurse. And thank you all for what you do to help prepare the young women and men that are going to become nurses and care for us as we get older. So thank you.
Thank you.
Okay. Thank you, and onward to the next session on our closing day. Marcia, do you have a minute to tell us goodbye?
I want to thank everyone for being here. I think it's been an exciting summit. I hope you agree. You know, for me, this ends my first year as the president, and I have one more year to go, and I am so very excited about serving and working with each of you. So we will meet again in Las Vegas. Viva Las Vegas! And so please, please remember there's still concurrent sessions, exciting concurrent sessions. So have a wonderful day, and I'll see you again soon. Bye-bye.